vaccination in RMD patients, what we know so far. I would like to welcome everyone and thank you for attending this webinar. And first we will go through some advices on how to attend correctly a webinar for a better live connection. So please try to join the webinar with your computer. Mute yourself when joining or you will be muted automatically. Turn off your camera please when joining, as this might ensure a better connection. And most important, if you would like to ask a question, please write it on the meeting chat or send it by email to pare@eular.org, and questions will be addressed at the end of the webinar. In case you experience any technical difficulties, please contact pare@eular.org. So after this first webinar guidance, I'm sure that we have put together a very interesting for you to attend. We will start by a short introduction. Why is vaccination a relevant topic, especially in the current times? And then two other interesting presentations will follow. EULAR recommendations for vaccination in adult patients with autoimmune inflammatory rheumatic diseases, and the current status of the research on COVID-19 in patients with RMDs and beyond. And we will be looking forward also for your questions, so please don't hesitate to write it on the chat. And starting to introduce myself, my name is Elsa Mateus. I'm the current chair of PARE, and I will provide a short introduction why we thought that this topic would be very relevant, especially in the current times. So for the next slide, please. Let's start by reflecting on the overall importance of vaccination. We know that the first vaccine was developed by Jenner in 1796 and against smallpox. And since 1979, after 2 centuries, and due to the large-scale use of the smallpox vaccine, this infectious disease is considered officially eradicated. This means that when enough people in a population are immune to an infectious disease, the disease is then unlikely to spread from person to person. This is known as community immunity, also referred to as herd immunity. Then vaccines prevent diseases that could otherwise cause serious health problems, permanent disability, or even death. And many infectious diseases are very rare today, thanks to vaccination. So the negative consequences of these diseases are sometimes forgotten, and we are certainly experiencing some of the issues around forgetting how infectious diseases could affect the entire population. So for the next slide. About vaccination programs. Individual European countries decide which vaccines should be part of their national vaccination programs and funded by their national health systems. And this is based on local conditions, such as how common the disease is, as well as economic factors. Most national vaccination programs in the EU and the EEA include vaccines for up to 20 diseases, which are given to people at specific ages. And in addition, vaccines to protect against specific diseases are sometimes recommended for high-risk groups, such as people with long-term health conditions or people planning to travel to other parts of the world. And RMD people are, of course, included in these long-term health conditions. For each European country, the European Centre for Disease Prevention and Control issues recommendations regarding the administration of vaccines for specific groups, and this is based on the latest scientific data. So for the next slide. Therefore, why is vaccination such a relevant topic for us? Well, immune-compromised individuals like RMD patients face a higher risk and a more severe course of certain infectious diseases, which can be prevented through vaccination. And there are, at least in my perspective, three major issues. Vaccination is strongly recommended, but it's not mandatory in most European countries. There are recent trends and movements against vaccination that are threatening the community immunity. And then, of course, we have this issue around, are the particularities of rheumatic and musculoskeletal diseases covered within the national vaccination programs? Or is the recommended vaccination increasing the out-of-pocket expenses for people with RMDs? And this could be very relevant when people with RMDs need to take a certain vaccine that is not included in the national program, and it's not for free, and the cost of the vaccine may be a hurdle. So for the next slide. And also, there are several types of vaccines. There are attenuated and live vaccines, inactivated vaccines that are killed vaccines, subunit acellular vaccines, and toxoid vaccines. This is, of course, a very specific terminology for us. But some vaccines are not to be given to the immunocompromised or should be given observing certain precautions in relation to their underlying illness or treatment. And this is certainly the case of people with RMDs. In some circumstances, a person can still get the disease even after receiving the recommended doses of a vaccine against it. And this is due to the person not developing sufficient protection against the disease or due to the immunity decreasing over time. In these cases, however, and this is very important and very relevant for our community, the person's symptoms are often milder than they would have been without vaccination. They are also less likely to infect others. These three items are very important to bear in mind when we think about the relevancy of the vaccination for the RMD patients. So the next slide. Well, of course, we are aware that there are a lot of myths and misinformation around vaccines. We have, of course, the vaccination objectors or vaccination critics that are refusing vaccination both for themselves and their children. And as I said before, they are threatening the community immunity. So I would advise to read the 20 most frequent objections to vaccination and responses by immunization experts of the Robert Koch Institute and the Paul Ehrlich Institute. They have gathered these arguments against vaccination and provided scientific and evidence-based responses that can be used to try and demotivate these objectors and critics of vaccination. And of course, if you are concerned about safety, quality, and standards, you can have a look at the vaccinationinfo.eu, this European portal around vaccination, and then have a look on the safety, quality, and standards that are involved when producing and introducing a vaccine to the population. And the next slide, please. One of the things that make this topic relevant for us now is also the concerns around the influenza and the pneumococcal disease, because you know in Europe overall, this is the season for both of these diseases. And we are, of course, also worried about the consequences of having these diseases in the COVID time. So it's very important to know more about vaccines and vaccination for RMD people so that we can try to prevent and do our best to protect ourselves. And the next slide. And finally, of course, one of the reasons why vaccination is nowadays so important for us is around the hope and concern around the COVID-19 vaccines. This print screen was taken late last evening, and it shows that there are 154 vaccinations in preclinical trial, and we are longing to have this kind of response so we can try to go back to something more like the normal life we used to have. But we do have, of course, other concerns regarding this new vaccine on COVID-19 that are possibly related to the fact that would this be a vaccine that the RMD patients could have with increasing the risks, but everything is ongoing, and there are still research ongoing, but we cannot lose our hope. And this is why we gathered this very interesting agenda for today's meeting and for today's webinar. And without further delay, I would leave the floor to Professor Ori Elkarian, and afterwards it will be Professor Xenofon Barakiakos, sorry, and they will provide hopefully some good issues for us all to know more about vaccination in RMD patients and what's to come. So thank you, and Professor Ori, the floor is yours.
Okay, thank you. Thank you very much for this very kind invitation. So I will try to give during this webinar the recently published update of the EULAR recommendations for vaccination in patients with autoimmune inflammatory rheumatic diseases. So as you all know, there has been a revolution in the treatment of rheumatic diseases, which includes the introduction of biologics and small molecules, which have improved very much the prognosis of the patients. But there is one issue that in fact has not been, is even perhaps increased, and it is the increased risk of infection in patients with rheumatic diseases. It may be inherent to the disease itself, but very often is related to the treatment. And we know that the most common sites of infection are the respiratory tract, including pneumonia, skin and soft tissue disease, urinary tract infection, herpes zoster. It is mainly an issue with the JAK inhibitors, HPV, mainly in SLE patients. And some of these infections may be prevented. But despite the different sets of recommendations from many sources, the EMEA, the CDC, the EULAR, etc., there is a very low uptake of vaccination among our patients. In fact, there are several studies which have shown that, but I would like to mention one of them, which is based on the COMORA cohort, which is a cohort of more than almost 4,000 patients with RA over 17 countries. And you can see here that the uptake of pneumococcal vaccination, the mean uptake is 17%, and the range is from 0% in Morocco to 56% in France. And the uptake of influenza is about 25%, the range again from 1% in Morocco to 66% in Japan. And I must say that some studies have shown that many times the patients are not offered to be vaccinated, and this is because the physicians often are reluctant to vaccinate the patient the toxicity of this vaccine. So in 2011, the EULAR nominated the first EULAR task force, and in fact, these recommendations for vaccination were published in 2011. But since then, there have been many new studies which have been published on this topic. And in 2019, the task force, in fact, formulated an update of these recommendations. And I will try to explain you what the rationale behind these recommendations in this update. So the task force was composed of representatives of 10 European countries, 8 rheumatologists, 2 clinical immunologists, 1 specialist in infectious disease, 2 pediatricians and rheumatologists, 2 delegates of Immunate, 1 health professional in rheumatology, and 2 patients. And the steering committee was composed of the convener, co-convener, methodologist, 3 fellows and 1 rheumatologist, and 1 specialist in infectious diseases. And the key questions for the systematic literature review were, first of all, to try to look after new studies, new evidence on the prevalence of vaccine-preventable diseases in patients with rheumatic diseases. So the question is whether the vaccine-preventable diseases are more prevalent in the population of patients with rheumatic diseases. And if it is so, these patients need special recommendations. But if it is not increased, well, the recommendation should be like in the general population. We also looked for an updating on specific vaccines in patients with rheumatic diseases in terms of the efficacy and safety of these vaccines in this population of patients. We look for data on the effect of DMARDs on the efficacy and safety of vaccination. And we also to look for whether there is some stratification of risk of specific infections in predefined groups. And last but not least, we also looked for some evidence on the recommendations for vaccination of the population close to patients suffering from autoimmune rheumatic diseases. So the SLR was really extensive because we included the literature that was published on a variety of autoimmune rheumatic diseases such as RA, spondyloarthropathies, lupus, Sjögren, MCTDs, etc. You can see the list here. And we also looked for the effect of different immunomodulating agents, all the immunomodulating agents that were available until 2019. As you can see here, synthetic DMARDs, biologics, and small molecules. And we also included all the vaccines that are recommended for the adult population. And these vaccines include inactivated vaccines such as diphtheria, hepatitis, Haemophilus, HPV, influenza, pneumococcal vaccine, tetanus, etc. And live attenuated vaccines such as measles, mumps, poliomyelitis, oral typhoid, varicella zoster, and yellow fever. So I would like to define some outcomes that are very important when you try to understand and to interpret the results of the different studies that have been published on this issue. This is a general definition, but it is perhaps even more relevant in the population of patients with rheumatic diseases. And we have to make the difference between efficacy, which is a capacity of vaccinations to prevent infection, and immunogenicity, which is a capacity of vaccines to induce humoral and cellular immune responses. So most of the studies that we have among patients with rheumatic diseases are based on immunogenicity. It is very difficult to perform trials aimed at the efficacy of the vaccines because you need a huge number of patients. You can see it from the COVID-19 now that you need at least 30,000 patients in order to be able to demonstrate some efficacy versus placebo. So most of the studies that the SLR is based on are based on the immunogenicity. For some vaccines, we know that the immune response is very well correlated with efficacy, but for other, it is not so well established. And of course, we also evaluated the safety of vaccines, which is a very important issue, especially in our population of patients. So we came out with the six overarching principles and 9 recommendations. So the first overarching principle is that the vaccination status and indications for further vaccination in patients with autoimmune rheumatic disease should be assessed yearly by the rheumatology team. The idea here is in the previous recommendations, we stated that we should perform an initial workup, but without, in fact, putting emphasis on the annual assessment. And so it was changed in this update. And I think that the main update here is that the responsibility for the vaccination program is on the rheumatology team. And this is because the rheumatologist or the immunologist is often the only treating physicians for these patients. And also he has the knowledge and expertise encompassing all aspects of the autoimmune rheumatic diseases, the effect of the different immunomodulatory agents on vaccinations. And it is the responsibility of the rheumatology team to make an inventory of vaccinations history, adverse events, and flares of the underlying rheumatic disease following early vaccinations. And we also thought and expect that that in fact this principle may perhaps improve the implementation of this recommendation, and that it may increase the uptake of vaccinations among patients with autoimmune rheumatic diseases. The second principle is that the individualized vaccination program should be explained to the patient, providing a basis for informed decision, and then be implemented jointly by the treating specialist, primary care physician, and the patient. So the idea is to, in fact, it's a new formulated principle which was not included in the previous recommendations. And in fact, the idea is to share the decision with the patients, of course. In fact, it is the responsibility of the rheumatologist to recommend the vaccinations, but also I think that the patients should be aware of the vaccines and ask questions and be informed about the possible advantages or adverse events of the vaccinations. Of course, this principle was strongly endorsed by the patients' representatives, and it put emphasis on the principles of the EULAR recommendations on shared decision making and consideration of patients' needs. The third principle is that the vaccination in patients with rheumatic diseases should preferably be administered during quiescent disease. I must say that this principle is a little bit problematic because we, in fact, we would like to vaccinate our patients before starting immunomodulating agents, and they are often they are already active before they start a new treatment. But the idea of this principle is that, for example, in patients with very active lupus or very active vasculitis who are probably under high dose of corticosteroids, we should not, this is not the time to vaccinate them. But in the cases of patients with rheumatoid arthritis or spondyloarthritis before treatment with biologics or methotrexate, even if they are active, we probably can't vaccinate them. And in fact, in terms of evidence, most of the evidence that we have are based on studies which have been performed on patients with stable diseases. There is one study which included 340 RA patients, including patients with moderate to severe disease activity. And in fact, it didn't show a significant difference in side effects, disease flares, or level of seroprotection following influenza with H1N1. So as I said before, we, of course, must treat every case by case, but the idea of the principle of this to vaccinate patients with active disease is mainly based on patients with lupus and vasculitis and less on patients with inflammatory arthropathies. So this leads us to the fourth principle, which is that we should vaccines should be preferably administered prior to planned immunosuppression, in particular B-cell depleting therapy. And this table summarizes the effect of what we know about the effects of the different DMARDs and biologics on the immunogenicity of influenza and pneumococcal vaccines. And for example, methotrexate reduces a little, mildly reduces the immunogenicity of influenza and pneumococcal vaccines. So we should try to immunize our patients before starting treatment with methotrexate. TNF-alpha blockers reduces a little bit the pneumococcal vaccine, but not the influenza vaccine. Tocilizumab doesn't affect the immunogenicity. Abatacept, there are controversial results on the effect of abatacept on immunogenicity. Tofacitinib reduces the effect of the pneumococcal vaccines, so we should try to vaccinate our patients before starting tofacitinib, but it doesn't affect the immunogenicity of influenza. Rituximab is the worst in terms of impairment of immunogenicity, and we really should try to vaccinate our patients at least 3 to 4 weeks before administering rituximab. And we know that the administration of influenza vaccine, for example, during the 5 months after a treatment with rituximab, probably the immunogenicity will be severely impaired. And of course, high dose of corticosteroids also may impair the immunogenicity of the vaccines. The fifth, the principle number 5 refers to the administration of non-live vaccines. And in fact, they can be administered to patients with autoimmune rheumatic disease during the use of corticosteroid and disease-modifying drugs. And in fact, there are many studies on influenza, pneumococcal vaccine, hepatitis B, tetanus, and Haemophilus influenza, hepatitis A, which has been administered to patients with autoimmune rheumatic disease under immunomodulating therapies. And as you will see in the specific recommendation for H vaccines, in fact, the immunogenicity is quite good. And we can induce a satisfactory immunoprotection in most of the patients without major safety signals. But of course, the follow-up in terms of safety in all these studies were usually short-term. And the last principles refers to the administration of life-attenuated vaccines, and this is a major change in reference to the previous recommendations. And you can see here that the task force stated that there were a lot of discussions on this principle, and the life-attenuated vaccines may be considered with caution in patients with autoimmune rheumatic diseases. This is a very big change in comparison with the last recommendation in 2011, where we stated that life-attenuated vaccines should be avoided in immunosuppressed patients, with the possible exception of herpes zoster and MMR. And indeed, in fact, we must be very cautious with the administration of life-attenuated vaccines in patients with rheumatic disease who are immunosuppressed. But I must say there are more and more studies, especially on the MMR and varicella vaccine in children, in many patients with GIA, which have been vaccinated even under biologics and without a major safety concern. But of course, we have to be very careful about that. And in general, we must say that the preferable window time for the vaccination with live vaccines is 4 weeks prior to treatment initiation. Although I must say that for the herpes zoster vaccine, which is a live vaccine, there is a study which has immunized the patient 2 weeks before starting tofacitinib and without any major safety concern. So the window is between 2 to 4 weeks before starting an immunomodulatory agent. So we'll move on with the recommendations, and we'll start with the influenza vaccine. And this is, as Elsa said, it is very relevant to this season and to these times. And the first recommendation is that the influenza vaccination should be strongly considered for the majority of patients with autoimmune rheumatic disease. You may ask, why to the majority and not to all the patients? Okay, so there were a lot of discussions about that in the task force, and in fact, we chose this formulation because, for example, a patient with ankylosing spondylitis who is only on non-steroidal probably is not different than the risk for influenza in these patients, for example, is not higher than in the healthy population. And there are countries where influenza vaccine is not recommended for everyone, for young people, for example. So that is why we decided to formulate the recommendation on influenza like this. But I must say that if we have the possibility to vaccinate our patients, even young patients with against influenza, we should do so. And there are several studies which have shown that influenza vaccination is efficacious in this population of patients. So it prevented. There are some very nice database from Taiwan on patients with rheumatoid arthritis and lupus, which have shown that patients who have been vaccinated against influenza have lower rates of influenza and lower rates of hospitalization and complications from influenza. So this is a very important topic. And in fact, there are not a lot of vaccines that have been proved to be efficacious in these populations of patients, and we have this data for patients with RA and lupus. And in terms of immunogenicity, there are a lot of studies which have shown that for most patients, in fact, the influenza vaccine is immunogenic. And as I said before, there are some differences between the different immunomodulatory agents, but in general, the response is good. there is one study which have evaluated the effect of temporary discontinuation of methotrexate 2 weeks before vaccination, and indeed they have shown that it may improve the response. And another issue is what is the vaccine that should be administered to this population of patients. As you know, there are different types of flu vaccines. There are the inactivated vaccines, which are used in the population of patients with rheumatic disease who are immunocompromised, but activated vaccines, we have trivalent flu vaccine, quadrivalent flu vaccine, and high-dose vaccine. And in fact, there is a very nice study from Canada which have shown that high-dose vaccine induces a better immunogenic response in patients with rheumatoid arthritis. So if this vaccine is available in your countries, you should try to ask for it and to choose it. But anyway, any of the inactivated vaccines are recommended in our population of patients. We should avoid the use of live-attenuated vaccine, which is a nasal spray vaccine recommended for children mainly and for adults until the age of 49 who are not immunosuppressed. So in our population of patients, it is not recommended. So the second recommendation addresses the issue of the pneumococcal vaccination, which should be strongly considered for the majority of patients with autoimmune rheumatic diseases. There is evidence in the literature that there is an increased risk for pneumococcal disease in patients with RA and lupus mainly. In terms of efficacy of the PVP-23, the Pneumovax, there is one randomized control study which has not demonstrated from Japan, which did not demonstrate efficacy of the PVP-23 over placebo. But there is one retrospective study which has shown that the relative ratio for developing pneumonia among patients who are not vaccinated is 9.7. So, but it is a retrospective study. There are a lot of studies on the immunogenicity, mostly on the Pneumovax, the PVP-23, many studies in RA, lupus, GIS, psoriatic arthritis, but there are not a lot of studies about the combination of the conjugated vaccine, the PVCV13 and PVP-23, which is now the recommendation when we want to vaccinate against pneumococcus. There is one study in RA which has shown that the combination of PVCV13 and PVP-23 has induced a very good immunogenic response. And there are some studies also in lupus, but they are not conclusive. In terms of safety, there is really no safety issues concerning the pneumococcal vaccine. It is a very safe vaccine, and the only concern is in patients in a very rare disease, which is the CAPS disease, the cryopyrin-associated autoinflammatory syndromes, where there have been several reports on severe local reactions in patients who receive the Pneumovax. So nowadays, the recommendations of most regulatory agencies are to combine the conjugated vaccine 13, the PCV13 or Prevnar 13, with the PPSV23, the Pneumovax. And in fact, we recommend to start with the PCV13 and at least 8 weeks later to administer the Pneumovax, the PVP23. As I said before, this recommendation is mainly based on studies which have been performed in patients with HIV and not so much in patients with rheumatic diseases. And we are really looking for more studies to evaluate the efficacy of the immunogenicity of these combinations in relation to the PCV13 only or the Pneumovax, the PPSV23. The third recommendation refers to tetanus, and in fact, we are not very much aware of tetanus in our population. There is not an increased rate, of course, of tetanus in patients with rheumatic diseases, and therefore, in fact, the recommendation should be in accordance to the recommendations for the general population, which is in general to vaccinate the population every 10 years. The only perhaps concern should be in patients who are treated with B-cell depleting therapy, where we are not sure that the booster of the tetanus toxin vaccination may induce an appropriate response. And if there is some concern about that, we may perhaps consider passive immunization. I must say that we also, it's mainly based on expert opinion of and in fact, the specialists in infectious disease saw that it is a very important point, but it is not based on reports and in the literature of more cases of tetanus in patients who are treated with rituximab or any other treatment. The recommendation number 4 relates to hepatitis A and B vaccines that can be administered to patients with autoimmune rheumatic disease at risk. We don't think that all the patients have to be vaccinated against hepatitis B, but we certainly recommend these vaccines in patients who are at risk. And what is a patient? Who are the patients are at risk? Concerning hepatitis A, it refers mainly to patients who travel to or residents to patients or residents in endemic countries. And concerning hepatitis B, the increased risk of exposure is related to the medical profession, infected family members, or contact injecting drug users and men who have sex with men. But in the other patients who are not at risk, they do not necessarily need to receive the hepatitis B vaccine. We know that there are no efficacy data on the hepatitis B and hepatitis A vaccines, but there are good correlation between antibodies and hepatitis A and B vaccines in the general population. And there are studies which have shown that concerning hepatitis B, the vaccine induces relatively good immunogenicity. Concerning the hepatitis A, the hepatitis A vaccine is composed of two doses of the vaccine, and in the general population, after one dose, you can obtain a very nice titer of antibodies. And it is not the case in patients who are immunocompromised. So a patient who is immunocompromised who plan to travel, perhaps not in this time of the COVID, but in the usual time, and we hope that we'll come back to the times that we are able to travel to endemic, to all kinds of countries, we must be sure that these patients receive 2 doses of the hepatitis B in order to be sure that he is really protected against hepatitis A. Herpes zoster. Herpes zoster is a very important issue. It is even more important in the last years with the introduction of the JAK inhibitors, which are definitively related to an increased rate of herpes zoster. And recommendation number 5 states that the herpes zoster vaccination may be considered in high-risk patients with autoimmune rheumatic diseases. In fact, we know that all the available vaccines nowadays, the live vaccine and the recombinant subunit adjuvant zoster vaccine, are in fact recommended for the population above the age of 50. And we must remember that it doesn't mean that we cannot administer it in the population below the age of 50, but we must be sure that these patients have been in fact infected by varicella, and we have to test for varicella antibodies before administering these vaccines in the population below the age of 15. In the population above the age of 15, most of them, more than 98% of them, have been exposed to the varicella, and they can, and in fact, they may be at risk for herpes zoster. And of course, the main problem is that in many countries, the only available vaccine is the live attenuated vaccine, the Zostavax, and it has been shown that it may reduce in the general population as well as in the immunocompromised population. It may reduce the risk for herpes zoster in around 50%, but it is a live attenuated vaccine, so there is some concern about patients who are heavily immunosuppressed. And nowadays, the recommendation is to vaccinate patients who are under methotrexate treatment with synthetic DMARDs, but not to vaccinate patients who are under biologics or JAK inhibitors. Although I must say that there are some studies which have shown that the patient the vaccine is quite safe in under treatment in patients who are treated with biologics. So, but the official recommendation is not to vaccinate them. Concerning the non-live recombinant subunit vaccine, it probably can be administered during treatment with biologics and JAK inhibitors. I say probably because there are not a lot of studies on that. In the late ACR meeting, there have been some studies which have evaluated the safety of this vaccine among hundreds of patients with rheumatic disease, and it is found to be safe. But we will hear more, and we are waiting for more studies on the efficacy and safety on the recombinant vaccine. So, for countries where we have the live attenuated vaccine, it can be administered, but it can be administered under synthetic DMARDs. We must be careful concerning the administration of the live vaccine in patients who are under biologics or JAK inhibitors. Concerning yellow fever, it is mainly relevant for patients who travel to countries who are endemic for yellow fever. This is a live vaccine, and it should be generally avoided in patients with autoimmune rheumatic diseases. In fact, as I said before, it refers to patients who travel to endemic area, and we must be careful with the yellow fever vaccine. And in fact, if the patient is treated with an immunomodulating agent, we should avoid it. We can try to stop the treatment if it is very important for the patient to travel, and if he travels to an area who is very endemic, or he must be warned that it may not be protected against yellow fever. So the recommendation number 7 refers to the HPV, and the patient with autoimmune rheumatic disease, in particular patient with SLE, should receive vaccinations against HPV in accordance with recommendations for the general population. In patients with SLE, there are increased rate of HPV infections and cervical dysplasia. It has been shown in many studies. Of course, in these studies, the variables that were associated with HPV infections in patients with SLE were multiple sexual partners, STDs, and the younger age. There is no efficacy data on the HPV vaccine, but there is good immunogenicity data, and we know that there is quite a good correlation between immunogenicity and efficacy of the HPV. In terms of safety, there are controversial results on flares after vaccination. There have been some reports on flares or onset of lupus after a vaccination with HPV, but there are only case reports, and in large-scale studies on the safety of the HPV in the general population. In fact, it has not been shown to be related to an increased rate of autoimmunity. Recommendation number 9, immunocompetent household members of patients with autoimmune rheumatic disease should be encouraged to receive vaccines according to national guidelines, with the exception of the oral polio vaccine. This is an expert opinion. In fact, we couldn't find any relevant literature on this important issue, but we know that in fact the idea is to create a sterile environment of the patients, and so we should encourage all the household members to receive a vaccine against influenza, pneumococcal, to also receive live attenuated vaccines such as MMR, rotavirus, varicella, and zoster vaccine. The only vaccine that should be avoided, of course, is the oral polio vaccine, and the children of parents who are immunocompromised, for example, should be advised to receive the inactivated polio vaccine. And concerning rotavirus, which is a live vaccine, in fact, the only recommendation is to avoid handling with diapers of infants vaccinated against rotavirus in highly immunocompromised patients. But for most of our patients, even those who receive biologics, this is not an issue, because the rotavirus, in fact, is not a very aggressive or a severe infection. And so children of patients who are under biologics, for example, may be vaccinated against rotavirus. And of course, patients who are immunocompromised should avoid contact with persons developing skin lesions after varicella or zoster vaccine. And last but not least, live attenuated vaccines should be avoided during the first 6 months of life in newborns of mothers treated with biologics during the second half of pregnancy. We know that the IgG crosses the placenta during the third trimester, and biologics are detectable in newborns of mothers treated with biologics until approximately 6 months. And there have been a case of disseminated TB in newborns exposed to biologics. So in newborns of mothers who have been treated with biologics during the second half of pregnancy should not be vaccinated against polio and rotavirus. And it refers only to the first 6 months of life. So what is new in this update? First of all, the responsibility for vaccination is on the rheumatologic team. It should be a shared patient decision. There is a new protocol for pneumococcal vaccines. We are more flexible in terms of live attenuated vaccines, and there are very specific recommendations on household members and newborns. Of course, there are a lot of things we need more studies on the efficacy and safety on vaccinations. I think that the issue of COVID-19 will be very fascinating in terms of in our population of patients, and we indeed would like to have more data on this in the future. And I would like to thank all the members of the task force, especially Vika Forer, Christian Rondan, and Marlo Heistek, who really have done a very important job. And as you see, the SLR was very, very complex. And I hope that this recommendation, in fact, will help the medical community and the patients in the implementations of vaccines. So thank you very much for your attention.
Well, thank you, Professor Adi, for your interesting presentation. I think it was very relevant for all of us to know a little bit more around this. And we will have a short moment for some questions. Savia, you have raised your hand. Do you have any questions?
Yeah, I have two, if that's all right. Hopefully they'll be quick. So the first is, I had a pneumococcal vaccine about 10 years ago. Would I need a booster with RA?
Yeah, it's a very good question. In fact, you need to receive the pneumococcal vaccine, the Pneumovax, twice in your life. I mean, if you received it 10 years ago, you should receive a booster now. And the booster should be indeed at least 8 weeks after the Prevnar, at least 8 weeks. It can be more than that, of course. And you know, there are not a lot of studies about this issue, but the official recommendation is to receive twice in a time life.
Okay, great. Sorry, and the other one was about the live herpes zoster vaccine. Is it worth stopping a JAK inhibitor to get that, like temporarily stopping the JAK?
Well, we don't have really data on how what is the efficacy on of the live vaccine in patients who are treated with JAK inhibitors. There are studies which are based on database from the US, which have shown that in patients who are on biologics, who have been vaccinated with the Dostavax, indeed it can prevent herpes zoster in about 50% of the cases. Now, if you stop the JAK inhibitors, you have to stop, for a few days, and then to be vaccinated, and then to wait at least 2 weeks before you renew it. So it depends on the patient. It depends on how severe is. If the disease is, in remission, it may be considered. But there are no very clear answer to this question. It's more a shared decision between the physician and the patient.
Great, thank you very much.
Thank you. We will have just 2 more questions for now, and I see that people are raising their hands. So please write your question in the chat, and we will go back to it afterwards. But before ending this part, there are some questions in the chat. What about tuberculosis? Because it's not anymore mandatory in some European countries.
Well, we don't think that, in fact, the BCG, you refer to the BCG vaccine, in fact, it is not recommended in general. I mean, we did not address the issue of the BCG. Well, this is a good point, because in the previous recommendation, there was a recommendation about the BCG that it is not indicated in patients with rheumatic diseases. And we decided not to address this issue because we thought that it is not relevant. The BCG vaccine is not a very efficacious one, and it is not relevant in our population. So.
Okay, thank you. And the last question for now, how long template discontinuation of MTX should be before vaccination?
Well, it's not an official recommendation. As I said, there are 2 studies from Korea about stopping methotrexate and in different protocols and how this affects the immunogenicity. And the idea is to stop it 2 weeks before and 2 weeks after. So and it can improves the immunogenicity, but it doesn't mean that under treatment with methotrexate the immunogenicity is not good enough. I mean, it is a little bit reduced in comparison with the healthy population, but again, this is something that you should discuss with your physician, whether really, if you have a disease that is really is dependent on methotrexate, I'm not sure that it is worthwhile to stop the methotrexate. But if you are very stable, we may consider it.
Okay, thank you. And someone else has the hand raised, so it's just one person.
Elsa, I have my.
Okay, I thought it was you, Marius. Okay, please proceed.
Do I have time?
Yes, shortly.
Okay, thank you. So excellent presentation. Thank you very much. Very interesting. I'd like to ask about the pneumococcal vaccine. As you said, we can have both, a combination. Which one should be the first?
Okay.
The 13th or the 23rd, or it doesn't matter?
No, it matters. It matters. It matters. In fact, if you have never been vaccinated, it's the first time, you have to try to start with the conjugated vaccine, the Prevnar 13, and at least 8 weeks later, it can be more, but not less than 8 weeks, you have to receive the pneumococcal vaccine. If you the Pneumovax 23, if you have received the Pneumovax 23 in the past, the time between the Pneumovax and the Prevnar 13 must be at least 1 year, and then you can receive the Prevnar 13. And if it is more than 1 year, there is no problem, of course, and you do not have to receive another booster of the Pneumovax until it is more than 5 years ago. Was I clear?
Thank you, very clear. Thank you so much.
Okay. Okay.
So thank you, Professor Odi. Thank you for a very interesting presentation. And now, without further delay, Professor Xenophon Paraliakos.
I'm here.
So please go ahead.
Thank you very much. So this is the topic of my presentation, and I would like to thank Elsa, Susie, and also Birte for inviting me, but also Diana for helping out with the preparation so far. And I would like to give a little bit of an update of where the current status of the research is, especially in patients with RMDs and also beyond when it comes to COVID-19. So you will see that it's not just what we know today, but how we came up to the entire situation that we have here. This slide is in German, but I would just like to bring it up because I collected it yesterday, showing in fact where I am. This is my county in Germany, and you see that unfortunately we are in the top 3 counties of Germany having positive patients for COVID. So what I was saying is that we're here, and unfortunately this brings me to the position to say that we seem to have some experience with what is happening with COVID-19, and this is not something that we are pretty proud of, simply because the issue is huge in the area that I live in. Now, starting with where we are now, I would like to nevertheless give you a little bit of an information of how this all started, and I will not give the entire story, but just the pieces of the puzzle to make the story flow a little bit easier to follow. And it started obviously last year already in China, as we all know, and we had also the first publications exactly from that area, from Wuhan, where they presented the first almost 100 cases of patients, not RMD patients, but cases overall, where with all the symptoms that they had and what the physicians there have found. And you see that obviously the most frequent symptom in the population, and you will see also the symptoms in RMD populations, but the most frequent symptom in the population was fever and cough. And of course, this gives us the problem that these are common symptoms in an area in the cold period of the year, which makes also the diagnosis and the separation between COVID and non-COVID very difficult. Nevertheless, also other symptoms were there, more severe or less severe. Shortness of breath is especially important also for patients with RMD when this comes up, which may also be a task for us to solve in daily practice. And you see that indeed 90% of those patients had more than just one symptom. And obviously also many of them needed oxygen therapy. I will also explain a little bit how this works and why that works later. And what they have published in that publication was that indeed, this is same patient. Indeed, this disease develops or worsens very fast. This is within 1 day. This is the normal, or let's say the X-ray of the patient in a more or less normal clinical condition. You may see these white spots here, which are already the affection of the lung, and within 1 day only, you see how the entire lung was affected, and the patient also had to get even more oxygen. So obviously, this is a very fast developing disease, and this is how it all started, at least the area of research there, because we have seen the first patients suffering from this diagnosis. Now, the question was then, what was the consequence of all that, not only for the daily practice, but also for research? And in daily practice, for research, I have to say that we have seen a massive increase. This is already, you see, this is only from March. I will go on to the next studies later, but this is already from March. There was a massive increase in studies that reported wanted to report data in patients with COVID-19, and you see that already in the very upper part, but also lower of this list, we have some of the medications that we may we also may see in rheumatic diseases. So overall, already in March, end of March 2020, almost 200 trials, and the number is steadily increasing. And this is something that is not yet updated from, at least from the way I know the data. Nevertheless, the ongoing trials and the trials that may also have ended in the meantime, that I will present later, have really dealt a lot with the medications that we are using, independent of the target that we are using, and you may also know better from yourself or from other patients. So obviously there is, in fact, almost only medication that we know from immunologic diseases that has also been applied in trials in COVID-19. And this is now shown a little bit differently. This means this goes with the not all about the trial, it's also about the mechanism of action. And in fact, what the target viruses are seems to be very similar to what we also target in rheumatologic diseases. Again, all of those treatments and compounds you may know from rheumatology. So in fact, we do have a lot in common with this disease in rheumatological diseases, and that's something that I believe is of special interest not only for the researchers but also for the patients. And you all know that this led to the establishing international databases and registries. I'm presenting here the two, to my opinion, most important ones, or at least the ones to us relevant ones. This is the overall Global Rheumatology Alliance, and this is just for EULAR or the EULAR one. And the way that this was conducted, and I really have to say that I was very positive to see that, was that the information that was collected was something that was easy to collect. It was not really something that would burden much in daily life, because of course we have to take care of the patients, but also have to type in the data. So I think that this is really very nicely conducted, and this also will give us, or has already given us, data that I will show you later. This is the status of yesterday, and we see that there is many patients, more than 3,300 patients included in this study or in this registry, with the different areas that may be reported. Here you see the first symptoms, cough, fever, the top symptoms, cough, fever, and shortness of breath, which means that we have in our rheumatology patients the same symptoms as we have it in the, I would say now, other population that is not primarily rheumatological, as shown from the data from Wuhan, but also from other studies. What are the treatments that patients are getting? They're getting conventional DMARDs still, they're getting biologics and targeted synthetic DMARDs. So obviously there is continuation of medication. I will speak about that now. And the male to female ratio is here shown, and I think that is an important thing, because I don't know if there will be any signal at the very end, but there seems to be that 2 out of the 3 patients that are being reported are females. These are the main diseases, but this might also be a little bit of a bias from the countries that are reporting more or less patients. By the way, one also important thing is that we have 50% hospitalizations. That's something that we'll try to speak about later on. Now, how is or was our daily life affected, and how did we then get to the research? I would just like to show you how our hospital looks like nowadays, and you have to know that these rooms here are rooms where patients are always sitting or maybe waiting for their consultation or their appointment, and they are always full. And this is what we see here today, or let's say in the last couple of days, they're all empty, simply because many patients are of course afraid to come to the hospital. This is someone who is always taking care of the patients who come in, and we are also recording everyone who gets in and out, and the times and the conducts as much as possible. And you see here that we have taken the precautions for having the appropriate distancing between patients. Nevertheless, this is indeed a sad picture, because we want to treat the patients and don't want them to be out of the hospital. And what we have also learned, and I found that nice, and I think it is nice to spend some seconds to show that, is that we have seen more than what the rheumatological community has shown. This means how we deal with COVID and the dangers of it for transmission in daily practice. I would like to draw your attention on the half-life of the virus in the very lower part of the slide. And you see here, this is SARS-CoV-2. This is our area now. This is the virus that we're dealing with today, and this is SARS-CoV-1 from many years ago, and we have seen that there has been also differences in the way that this virus behaves, which means also we need to take care of that either by disinfection or others. For example, on the cardboard, this is having the virus is staying much longer than the previous virus many years ago, but also on plastic and on stainless steel. This might be of a long half-life. This means how long the virus is alive, although if somebody who is positive has touched that kind of area. Now, going back to COVID precisely, what have we learned, and how does this impact our daily life? This was also very recently published. This is taken from New York, and you all know that New York City was an area with a very high number of patients being affected, and unfortunately also dying. And what you see here is the black and white lines that you may see in each of those panels, which mean that for the different ages that are being displayed and for the overall population, the numbers of patients who have been, the estimated number of patients who have been positive has been increasing. And once the measurements that I mentioned, this means that the staying at home or the public schools were closed, this to me means social distancing, then the numbers have gone down again. This is not because of less testing. This is because of less positive patients or the same amount of people being tested. This means that the precautions that we have all, not only in New York or in Germany, we have all been taken care of, have an effect. The other thing, of course, and that's something that I borrowed from this ACR Congress, which has just been, has finished just 1 or 2 days ago, is that it has infected our daily life in rheumatology, because obviously our patients with an autoimmune disease, as compared to those who have no autoimmune disease, seem to have indeed the same or similar concerns about COVID-19. So it's not that our patients do not care or do not bother or leave it to the physician. The amount of patients who are highly concerned is similarly high as those who do not have this kind of diseases. And the association with greater concerns was, of course, and as expected, to older patients, female patients. Here they put in the black race also because they had many patients from that subgroup, those in urban residents, and obviously those who then got infected. And this is the overall information. And in those with autoimmune disease, I think that's something that we can discuss based on the treatment. Those on any kind of treatment, this means biologic, JAK inhibitors, glucocorticoids, and those with systemic lupus who need generally more medication were highly concerned. And we have seen that this, and I just try to close the circle now, this has obviously shown that if we make a survey and ask people who suffer from inflammatory rheumatic diseases how this has impacted their daily life precisely in Europe, then we will see that, I take now this example, those who would come in for a follow-up visit, this means not the ones with a new diagnosis or those who are getting the diagnosis during COVID time, but those who have already the disease and would come in for follow-up visits. We've seen that there has been a decreasing number, I take out the red to see that better, the decreasing number of visits as with longer closure of the hospitals. And this has to do, obviously, and this, by the way, it was independent on whether or not people or physicians applied remote consultation or not. This obviously leads to the fact that patients are not getting their medications. This leads to the fact that patients may also be disinformed or uninformed, which of course leads to issues with the course of also the rheumatic disease in general. And I've seen also this study that I like to bring it in. This was the assessment of the pandemic from the perspective of people with RMDs from that study, where many patients associations obviously have participated. And what was shown was that, and I did like this result a lot, that in the vast majority of the patients, the medication was not changed, only 16% changed their medication. And this was obviously in the vast majority of the cases decided by the healthcare team, which I believe is a good way to do that. Nevertheless, I would like to know if the patients had agreed on that. This was, at least the way I understood the data, not entirely shown here. I was nevertheless concerned about this year. 5% of the patients said I was unable to visit my hospital for my treatment. Now, what are the symptoms of patients with RMDs when they, or in the early days of the pandemic? And these data have shown, they were just published, by the way, they have shown that obviously fever is indeed, even now after, let's say, so many months with experience and also with experience of how to deal with it, with COVID-19, still fever is the main symptom. And especially patients, these are the patients who are positive, each dot of them, especially patients who are comorbid were more frequently positive and assessed by those symptoms. And the other thing that I also read with interest actually yesterday evening by reading the entire paper once again was that there were a lot of not only RMD related, this means musculoskeletal, maybe even related concerns, but also other symptoms that patients experience. And I believe these are the things that we are maybe not even getting to see, because patients, if they have a remote consultation, may not even report. So I think the overall picture is very important in that respect. Now, what have we learned in the meantime about COVID? And I just write it out once again here for the ones of you who may have not known exactly what COVID means. This is the coronavirus disease. So this is the disease status with COVID. SARS-CoV-2 is the virus itself. We've learned that there is a kind of what we call tropism. Tropism means that something, a trigger, in that case the virus, may have a preference for one specific area of the body. Like, for example, in rheumatoid arthritis, we know that specific joints may be affected and not the others. In spondyloarthritis, we know that the inflammation goes to specific structures. And also here, there is a tropism for the virus, which goes and sits in the lower areas, mainly on the lower areas of the lung. And what happens is that it causes permeation. This means that the vessels widen, and then we also not only get more blood in and out of the tissue, but we also get many little thromboembolisms maybe, which then make cause the lung to collapse. And the cytokines, the cells that are involved in here, are also the ones that we know from rheumatological diseases. This is why I mentioned before that obviously our drugs seem to work pretty well, and there's a lot of research going on with the drugs that we all know about in this area with COVID positivity. And we know that the more severe the disease gets, the more those cells, the more those so-called cytokines will be involved. Now, what about the characteristics between patients with rheumatic diseases and those without? Again, from the US, and I found that also pretty interesting. I mentioned that before, the symptoms may or may not vary. How does this look like? Well, it seems that the symptoms that we have here are similarly frequently seen in patients with rheumatic diseases as compared to those with COVID-19 without rheumatic diseases. Those P values are all non-significant. This means that we have, again, the same symptoms with or without rheumatic disease, which makes the story a little bit easier in terms of saying that we don't have to deal with different symptoms. Nevertheless, of course, we need to think about medication and co-medication in our patients. That's something that, of course, may be of concern, but we have obviously to deal with in daily practice. One thing that I would not like to spend too much time on, because I also have seen that the time is going on fast, is that once you get, you know that you get tested, The research nowadays shows that indeed, especially when we take the PCR test with the nasopharyngeal swab, which is what we are also doing in daily practice because it's easier to perform in a hospital environment, we know that that test may be positive for more than 2 or 3 weeks, which again means that if you're here and you're positive and in the second week you're still positive, it doesn't mean that you're sicker than others. It just means that obviously, especially after symptom onset, that might be that the test is still positive and it will decrease or may get less people positive later on. So it takes some time to get a negative testing. Now, what is the professional organization guidance on COVID-19 and biologic therapy? What did the research show us? I will only quote the EULAR recommendations here because, in fact, they are very similar to the ACR and other recommendations. There's many of them. I will not go through them totally. Just 2 things that I would like to point out is that we have defined, or EULAR has defined mild symptoms, worsening of mild symptoms, and significant symptoms here with the symptoms that I actually already have mentioned. And the 3 things that I think are most important is that when we say that patients with RMD are following, when we apply these recommendations, in patients with RMD who do not have suspected or confirmed COVID-19, we would continue the treatment. In those who are clinically treated with glucocorticoids and have symptoms of COVID-19, cortisone should be treated if they are chronically treated. That's the important thing here. And in patients with mild symptoms, then we have to discuss on a case-by-case basis of how to treat the patient. Now, I go into this treatment and say, if I would be a patient, I would ask my question, what is the risk or the benefit of my treatment by continuing, stopping, or changing the treatment overall? Just very few examples. In fact, I would say upfront that almost all drugs that we have in rheumatology seem to work, at least this is my experience, pretty well, even if you're positive in COVID and if you have symptoms. Again, one example is colchicine here. This is not directly let's say, what we call a very broadly used drug in rheumatology only. So we use it also in other patients, but we see many patients who may use colchicine, and we know that by inhibition of specific factors, like, for example, the inflammasome, we may effectively affect the parameters that I already mentioned. I guess very briefly how this works. So don't be afraid of that, to my opinion. We also know that other biologics, for example, may be recommended. This is a study that was published a couple of months ago, assuming that, especially when it comes to viral infections, the biologics that we have, despite JAK inhibitors, may be something to consider in this disease. I go over that text. Nevertheless, and I will show you what the JAK inhibitors may do nowadays. One example has been, for example, that if we use tocilizumab, the IL-6 inhibitor, we have better outcomes. This is this curve here as compared to the standard of care. This means, indeed, this is just not a theory. This has also been shown in cohort studies with patients with severe COVID-19. And for the JAK inhibitors, in the meantime, I have to say we have positive data in terms of, these are the black numbers here, the black figures, that at least for mortality and admission to the intensive care unit, there might be some positive result. This means at least they do not harm. And what we also know is that if we check in our rheumatic diseases, and this is from the Global Rheumatology Alliance registry, and check the hospitalized and the non-hospitalized patients, we have seen that obviously there might be differences in the numbers who are or who are not hospitalized out of this large cohort that I mentioned. Nevertheless, there has been no huge differences in the treatment between hospitalization and non-hospitalization, with exception of the corticoids. But again, I mentioned already what EULAR has recommended about the chronic use of corticoids before being positive for COVID, in case somebody gets positive. I would just like to add that the conclusion of that study has been that indeed neither the exposure to DMARDs nor to NSAIDs was associated with increased odds of hospitalizations. Corticoids below ibuvio or above 10 milligrams per day should be something to consider when we talk about the risk of hospitalization overall. And again, here we have a very positive signal out of the data that we have obtained so far. Just wanted to show you how this looks like in the lung, just as an example. This is a patient with RA, 70 years, female. This is taken prior to the infection. A couple of months later, the patient got infected, got admitted to the hospital. This is how it looks like. This is the things that I showed you, this blood and the collapse of the lung, that not the collapse, the affection of the lung that I mentioned. And then the patient took a biologic. In that case, this was tocilizumab. Just by chance, it could have been also something else, and she recovered. This is again taken a couple of months later. So we do have positive findings. It doesn't mean, of course, that everybody should get the drug and they're doing well, but I just want to take away a little bit the danger of someone thinking that that we are in danger by the drugs we are applying. So what is the status of vaccine development as of today? We know that there is many different types of vaccines. I borrowed this slide only because I know that Ori knew that Ori would do the perfect job on explaining how the vaccines work. Overall, we have many different types of vaccines in terms of the viral components within. And then this is what happens in the body. This means how the vaccine works in there to get the immune response. I believe what we, in this round that we're speaking here, we need to take care of is the overall research that is being done. This is just a snapshot of what is taking place nowadays. You may have heard that this vaccine here in the collaboration between BioNTech and Pfizer is very close to approval. And the question is, of course, what does that mean for us, physicians and patients and physicians? What was obviously published is that this vaccine candidate was found to be more than 90% effective in preventing COVID-19 in participants without evidence of SARS-CoV-2 infection. The word effectivity or efficacy, or how effective this means, Ori already mentioned and explained in her presentation. I would just like to show you that obviously what this means in particular here again is that the case split, and that's I've taken from the internet because I think it's very well worded, between vaccinated individuals and those who received the placebo, indicated that the efficacy of vaccine rate was above 90% 1 week after the second dose. This means that the protection is achieved 28 days after the initiation of the vaccination, which consists of a 2-dose schedule. This means 9 of the 10 patients had the protection. So I would like to end my presentation with this slide, which I found pretty nice. I know there is still a lot of resistance about the measurements that have been taken. However, I think I showed you in the one slide how much they indeed bring in, and we all hope, of course, of the vaccination, and hopefully we will get this very soon. And thank you very much for your attention.
Thank you, Xenophon, for such an interesting presentation. And I do understand that we are over time, but this also shows the relevance of this topic. And still we have some questions, and I will try to address them. There was this question about, are there any other recommendations to enhance protection, overall protection in the case of the other vaccines? This question from Louise. For example, if vaccination becomes extended to family members, I would like to say that at least in Portugal, our recommendations for RMD patients and most of chronic patients that need to have vaccines is that the people, the family members and the people who lives in the same house with this person should also get vaccinated. So, or Professor Orion or Xenophon, can you please?
I can just give a very short answer that we do it similarly. Ori, you can also comment on that.
Yes, well, I think it is also, as I said before, it's one of the recommendations. Absolutely, we should encourage the household members to be vaccinated, to receive all the vaccinations. Absolutely, yes.
Okay, thank you. And we have 2 or 3 other questions. Savia was asking, are more females reported in the COVID registry because of RMDs tend to affect women more?
This might be that because of the overrepresentation of rheumatoid arthritis, that might be the case. On the other hand, of course, we need to see the proportion of patients who are female and male and see there whether or not there are differences. Because we also have other RMDs, which are, for example, spondyloarthritis, where we have a male predominance. This might equalize that. I am not so much into this data to know them by heart, but I would assume that this is one of the reasons.
Yeah, and the other thing I could add that these registries are built upon is the physician who reports and provides input
Yes.
to the registry.
Yes.
So it also depends. It's not because it's a build. You have to provide the data. It's not. It does not include every case of infected patients. So this must also be bear in mind.
Yes.
And Anya asked, are we better protected against the virus with biological treatment?
If protected by biologic?
Yeah. If you are taking biological treatment, are we better protected against the virus?
I will tell you my personal opinion, and because I tell my personal opinion sometimes and people may not always share my opinion, I just say that this is my personal opinion. So no, you're not protected against the virus. But if you're getting a biologic, you have, at least this is my experience with more than 1 or 2 patients, you have a much milder course of the infection. So I would not stop the biologic even in a positive situation, although I know that this might go against the one or the other national recommendations we've seen at the EULAR recommendations that we say decide on the case-to-case or case-by-case situation. So the protection is not there, but the course of the infections and the disease is milder.
Okay, thank you. And we have 2 more questions. One from Violetta. How long should we wait after symptoms of infection to resume the biological treatment when it's interrupted? In this case, he was referring to certolizumab.
Yes, again, I would still not stop it. I would like to know if Ori sees that differently, because I think that's an interesting discussion, and people may have also different opinions, not because we know it better or less good, but also because our experiences may be different. So Ori, do you see that similarly? Stop it or not? Because
well, I think that it depends on the disease, on the severity of the COVID, I would say. Yeah. I think in the patient with very mild, I think that we don't need to stop it. The patient was severe severe COVID, I think that it really depends, it's difficult to tell now, but I think that most of us will stop it, probably not Actemra, but not tocilizumab, but the other one, probably most of us would, that's what we have done now for patients who are very severely, with severe COVID-19. I'm not sure what is right here, of course, but this is what we do.
No, this is exactly what I said. As you see, we may, I would say that it is rather better to protect the patient by the disease activity itself, because this will also worsen the COVID infection. This is again why my opinion is to not stop the drug, as I showed also the cytokines that are responsible for the RMD, for the disease, are also responsible for COVID. Of course, if somebody is in the ICU, we have to decide possibly differently. I don't disagree, but in all the cases that we see in daily practice, I would not stop. And if the question is when should I restart, I would say restart as soon as possible, because it makes clinical sense.
Okay, thank you. And the final question we have here is from Amy, and she is asking if RNA vaccine is okay for RMD patients.
That is the question I have expected to not ask me, because I have to say that I need to read myself more into that. I would say that we need to see how, let's say, how the general population without any chronic disease responds to that. But I would like to also know Ori's opinion, because she's certainly the more expert in that.
Yeah, well, I think that there is absolutely no experience with RNA vaccines in the general population, as well in the rheumatic disease, population with rheumatic disease. And this is a very good question. And I think that I completely agree with you. I think we will have to be very careful with that with our patients. We really don't know what will be the safety in our patients, if there is any issues with that. Absolutely no experience with that in in the general population. So it's a new concept.
Yeah.
Okay, so thank you for your questions and for your presentations. And now it's time to end this webinar. Thank you so much again, Professor Xenophon and Professor Adi for your presentations. And thank you all for attending. But just before that, in my opinion, 4 key messages that we should take. Do not disregard your individual vaccination plan. And very often as adults, we tend to forget that we still need to keep our vaccines up to date. Talk to your rheumatologist and promote communication with the primary care physician to have your vaccination in order. Find reliable sources of information. And of course, that patient organization can also have a role in promoting vaccination. So once again, thank you all for attending and have a nice rest of the day and keep yourself safe. Bye-bye.
Bye-bye.
Thank
Bye.
you. Bye.
Thank you all. Goodbye.